respected chairpersons, my teacher, Professor Sundaram, senior members, and my dear friends. At the outset, I sincerely thank the 3D Vijayakumar, not this 3D, dynamic, devoted diabetologist, Dr. Vijayakumar, for having given me this opportunity to be with you and to discuss a very important topic, GLP-1 receptor agonist. I will take you through a little bit of introduction. I'll touch upon the physiology and how the pathology happens with respect to the incretin therapy. What are the GLP-1 receptor agonists which are available, and how do they really act? What is the mechanism of action? And what are the newer drugs in this particular spectrum of anti-diabetic drugs and their potential adverse events? And in the special situations wherein you could probably use it, and end up with summary. To talk about this GLP-1 receptor agonists, they are physiopharmacological peptides or compounds which have revolutionized the treatment of diabetes mellitus. Here, the theme is a physiological approach, but with a pharmacological addition or modification. Thereby, you get physiological effect through a pharmacological agent. And primarily, they are cell regulators confined to beta cell and alpha cell in achieving glycemic control. But beyond that, they work wonders in reducing apoptosis as well as to increase beta cell mass, which is really supposed to happen. These are chemical mediators connecting and linking with other tissues so that apart from achieving euglycemia, you get a lot of metabolic derangements getting corrected. Being a physiological stimulant of beta cell in a glucose-dependent manner and suppressor of glucagon, it really prevents the wastage of insulin. Coming to the physiology and pathology, GLP-1, as you know, is released by the L cells of ileum, and GIP is released from the K cells of small intestine in response to a neuronal stimulation via vagus as a first phase. And then when the food enters the intestine, it produces a second phase of incretin release, just like how we studied the gastric acid, which has a cephalic phase and a gastric phase. The incretins act on the respective receptors to have this particular action in a glucose-dependent manner. And unlike sulfonylureas, it not only releases insulin, but also augments the insulin secretory mechanism. And between these two, GLP-1 is more potent an insulinotropic agent. Both of them have a synergistic action in an additive manner in a normal person. Incretin defect, which is rather misunderstood, that it causes glucotoxicity, whereas it is not so. It is the glucotoxicity which worsens the particular incretin defect. GIP also reduces insulin degradation, so you have a little more longevity of insulin action. Now, as you know, the glucose entering the beta cell stimulates the secretion of ATP, and ATP-ADP ratio is altered in a favorable direction, releasing calcium into the cytoplasm, and the actin-myosin filaments of the beta cell push out the insulin molecules. And in the presence of GLP receptor agonist or in the normal physiological function, you have one more addition of mechanism to enhance ATP, cyclic AMP. Thereby, this particular entity also improves the ATP level, increasing the insulin secretion or augmenting insulin secretion apart from the glucose-dependent manner. Next is not only the release of insulin, but also the same thing continues to act through the pKa as well as EPAC, thereby stimulating the gene transcription for insulin secretion. So more insulin is released by this mechanism apart from insulin secretion, which is enhanced. So with that, we move on to what are the certain myths about this. As I told you, incretin defect is not the cause. It is the glucotoxicity which causes a reduction in the GLP-GIP effects. If fasting is less than 100, it is probably very good. Everything is normal. If fasting is just more than 100, less than 150, the decline of GLP activity is identified. And if it's going to be more than 150 to 250, GLP refuses to act. So that is how very often we see that we are not able to control these drugs, maybe with a DPP-4 inhibitor or a GLP-1 receptor agonist, or able to do it better. And it gets corrected to some extent. The next thing is, another interesting fact is that the insulin degradation, which is normally happening in the kidney, in CKD, you have a reduction in the degradation. In the same way, when there is a drug or physiological action of this particular drug, you have a reduction in the degradation of insulin, so that insulin lives longer and is able to give you better control. And there are newer concepts about GLP and GAP. One is that we had an idea that there is a deficiency in GLP-1, which is secreted by the L cell, and there is an increase in GIP secretion by K cell, and also the GIP resistance at beta cell. The last concept is a little more improvised, and they have found out there is no increase in GLP-1 or no change in GLP-1 or GIP secretion. However, there is a reduction in the GLP-1 induced insulin secretion. So it's not that much effective. And almost complete loss of insulotropic response to GIP. And as you know, the GLP-1 is degraded, and only 10 to 15% of it roams around in the circulation, escaping the DPP-4 action. These are the GLP-1 receptor agonists that we have in our midst for our prescription: exenatide, liraglutide, dulaglutide, lixisenatide, and semaglutide oral. How do they really act? As I've already alluded to, stimulation of insulin gene transcription is a very important key factor. And mRNA transcription of glucotransporter 2 helps mobilizing more glucose into the beta cell. Thereby, you have the glucose responding well with a form of insulin secretion. The beta cell viability and survival is enhanced, apoptosis is lowered. The size modification, hypertrophy of the beta cell, all these things do happen apart from replication, islet cell neogenesis, as well as the acute and chronic effects of incretin. These are the unlucky 13s. So we go on adding on from 1, 2, 8, 11, and then now we come to 13. Of the lot, there are problems which has been included now, including testosterone deficiency, vitamin D deficiency, and other things. And of the lot of the 13, this particular drug is able to control 6 of the pathogenic mechanism. Thereby you get a correction of the pathological aspect. So that is why this particular topic has been included under this symposium. This is how GLP-1 act on the islets. You see here on the left a violet color receptor, the GLP-1 receptor, on which a GLP-1 is sitting on and stimulating. It is able to stimulate a cyclic AMP, P13K, as well as the MAP kinase. By these mechanisms, you are able to achieve a better ATP formation in the beta cell, as well as a reduction in the caspase, which is a very important entity for apoptosis. So ultimately, we achieve a pro-insulin gene expression which is enhanced, pro-insulin translation which is enhanced, beta cell proliferation, neogenesis, and a reduction of apoptosis. These are the newer drugs in this particular area. As you know, in any election, you always try to take up one more party so that you will have chances of victory is more. In the same way, GLP-1 or GIP, when they're alone, you may not be able to achieve great. So they have combined these two as to fight against this particular disease, diabetes. Not only 2, now it has become even 3, including glucagon. And another thing, which is a very good opening out of a new channel, that is a chemical mediated entity called R4-glyperon. And this is a drug which is going to be probably the oral GLP-1 which is going to come up in the market soon. So tirzepatide is a twin creatine, and with a dual GIP-1 and GLP-1 agonist together, replicative of normal physiology. We forgot that GIP also has got some role. We were concentrating only on the GLP-1 receptor agonist. So today it has become both together, acting in a very favorable one. And synergistic benefit in glycemic control and weight loss. And it has a more favorable CV outcome. And Manjora 5, 10 and 15 milligram for type 2 and Zepbound for weight loss. There were two trials, the Surpass 2 trial and Surmount trial, wherein it was almost equal to semaglutide, which is slightly more favorable, and Surmount trial, which showed a 22.5% weight loss. This is a very interesting slide to tell you about the good and the bad elements. So in any family you have, the husband has some good qualities, some bad qualities as usual, and the wife has got very many good qualities and very few bad qualities. So when you combine these two, a good family is born, and probably the child should develop the best of it. I still remember Cleopatra went to one of the very great learned person, Socrates, and said, "Oh, if you both marry, then you'll get a very intelligent and a beautiful child." He said, the vice versa could also happen, an ugly, at the same time, a brainless person. So all these things are possible, but when you combine GLP-1 and GIP, you get the best out of it. The first thing is nausea, which is going to be a problem with the GLP-1, is countered by the other one, GIP, which produces less of nausea. The glucagon suppression which happens with GLP is countered by a glucagon excess with GIP. And the action of this particular drug on the liver is more with GLP, reducing fasting hyperglycemia, insulin resistance at the liver. And with GIP, you have the action on the skeletal muscle and the fat cell. So all these things together, put together, gives you a very good benefit. And retatrutide is a triple agonist with glucagon. I was really worried. How can you give glucagon? Because glucagon, we always consider it as an enemy. But the enemy is actually so helpful in this situation because hyperglucagonemia has two important effects. One is that it stimulates insulin secretion. So indirectly, we get benefit out of our enemy. And other thing is that you have the receptors of GLP-1 and 2 getting down-regulated, which is prevented by this particular glucagon. So in that way, better action of GLP-1 and GLP and GIP in association with glucagon. R4-glyperon is an oral drug, receptor agonist, oral formula, and obesity and diabetes are the indications. Long duration of action, so once day dosing, better availability, significant glycemic control, and body weight reduction. The unique features of this is, first, non-peptide, chemically synthesized drug, and also no fuss about taking it before food, after food, with water, without water. And despite partial antagonism, the efficacy is more. And we just have to understand that 71% achieved a body weight reduction of more than 10%. And weight reduction also has not plateaued out. So maybe till whatever time you want to reduce the weight, you can go on continuing it. But we don't have full evidences, though I have been a part of the phase 3 trial of this particular molecule. But I don't know whether the patient is on placebo or on the drug. But I have appreciated weight loss and a good control. Results match injectable semaglutide and also extra benefits like BP reduction, lipid friendly, and probably less cost. This is just to show you the efficacy of these drugs. R4-glyperon is almost equivalent to semaglutide, and the tirzepatide is the highest efficacy drug. So also weight loss is much more than the conventional GLP-1 that we have. And these are the potential adverse effects, which you already know: retinopathy, thyroid problem, hypoglycemia very rarely, and also cardiac increase in heart rate. That is one thing, apart from pancreatitis and so on. The special situations with chronic renal failure or chronic kidney disease or diabetic kidney disease, whatever you call it, you have the permission to use it till ESRD. Cardiovascular risk reduction is obvious. That is why a big column is there. Whenever you have ASCVD or CKD, you could use this particular drug. And driving, though it is not a contraindication for diabetics, of course, this drug may be much more better because hypoglycemia is less, and probably the driver will be safe for himself, his passengers, and also for the oncoming vehicles. And traveling, when you travel across the time zones, this also will be easier if you have a GLP-1 on board. Glucose variability is much better because you have a fine tuning of glucagon as well as insulin, and it could also be an indication tomorrow as far as NASH and dementia is concerned. And to summarize, GLP-1 receptor agonists have come to stay and found to be one of the most useful drugs in the management of diabetes, and also acting on the pathogenic mechanisms, thereby you are able to get down from the disease. Several understandings we have reformed, we have corrected ourselves. And the combination of these three have been found to be more physiological and effective. Adverse effects are minimal, and added benefits of weight reduction and the favorable effect on comorbid conditions, whether it is kidney or heart, or probably even days to come, the liver. An upcoming non-peptide oral preparation would probably be a near ideal anti-diabetic drug. So with that, I sincerely thank Dr. Vijayakumar and the scientific team and my co-chairpersons and the audience for a patient listening. Thank you.